I'm Anna Saucier, host of Cycle Power Summit 2019, and I'm here in this session with Dr. Nicholas Kongoasa. Dr. Kongoasa is a specialist in minimally invasive surgical techniques. He founded the Center for Restorative Reproductive Surgery in Atlanta, Georgia, to fulfill his desire to focus on enhancing fertility as well as treating endometriosis. Most recently, Dr. K opened the Reproductive Health and Gynecology Center, where he aims to take a restorative approach to abnormal reproductive system function. Dr. K, welcome. It is such a pleasure to have you here for Cycle Power Summit.
Thank you for having me.
Of course. Now, Dr. K, I want to talk about this common practice in our traditional Western medicine to take either a suppressive or circumventive approach to abnormal function in the reproductive system. So, for example, if a woman is experiencing heavy bleeding or pelvic pain, we, for example, use medications to minimize the symptoms or eliminate them, right? And also on the flip side, if a woman is struggling to get pregnant, to get pregnant naturally, then let's use other means or introduce whatever we can to get her pregnant. Can you talk to us about how your approach is different?
So I think that there's just a disconnect between symptoms and causes, right? So in our practice, our goal is never really to say control the bleeding or control the pain or give a couple a baby. So that is not really our goal. Our goal is more figuring out why are you having bleeding issues? Why are you having pain? Why are you not able to get pregnant? And then let's look at the reason why, and then let's treat that. So in a sense, it takes more of a really looking at the root cause of issues, and then let's try to correct that, so that now you have less pain, so that now you have regular cycle, so that now you can conceive. And I think that when we do that, we are doing more service to our patients, because we are restoring their health. We are restoring something that is not normal back to normal.
Right, which can probably influence a lot of other systems and things going on in the body, right? But we can't look at it as an isolated function like, oh, you're not getting pregnant, let's get you pregnant. But they assume the underlying causes of that can affect so many other things.
That's right. So for example, if the traditional artificial reproductive techniques, the IVF, for example, when you circumvent, when you are circumventing or when you are bypassing the abnormal function, you are not really, you're actually disregarding the issue and not really treating the issue. For example, if someone is not able to get pregnant, say because of endometriosis, for example, meanwhile they are also having pain, the IVF, for example, may produce a baby, but as you can see, this doesn't really treat the endometriosis, so the woman end up still having pain or having other issues from endometriosis, even when she has a baby. When we are restoring health, for example, we are actually let's kind of take care of endometriosis, let's do surgery, let's exercise the endometriosis. So now you're not in pain anymore, and you have a baby. So this is just a much more logical and also more efficient approach, I would say.
Right, and then you actually have a healthy body again, right?
That's correct.
Now, I noticed on your website you have 3 main areas that you're looking at in order to take this restorative approach. And I'd like to ask you to break those down. So you have reproductive endocrinology, reproductive physiology, and reproductive immunology. So could you just talk about what each of those terms mean?
So reproductive endocrinology is, I think, that's one of the areas that's was studied a lot in the past, and I think that now it's is gaining more and more traction, especially around the restorative reproductive medicine community. Endocrinology is essentially the studies of hormones. You know, as you know, male hormonal status is basically a flat line, 24/7, 5 days. But for a woman though, the level of hormones in the body changes day by day, and it's such a very delicate situation to bring about ovulation, and you need that variation in your hormones for follicles to grow, for follicles to be selected, and for ovulation, and after that as well.
So we just want to recap that. So endocrinology is basically the study of hormones. So when we're talking about reproductive endocrinology, it's the hormones that are affecting the reproductive system, which we know they're all connected, but there are the main hormones that affect reproduction, right?
That's correct. So we look at that. We look at that aspect. If someone is not able to get pregnant, we look at that to see, is there any kind of hormonal dysfunction somewhere, and let's try to correct that, so that then that will restore ovulation. Reproductive immunology deals with the immune system, and I think that is more relevant, I would say, in patients, for example, who has implantation failure resulting in infertility, and also in patients who have miscarriages. And as you know, mom and baby are totally different identity, and this foreign identity is living within the womb of mother, and yet the mother is not mounting a huge immune response to it. For example, like in a organ transplant, for example. So we know that there's a huge immunological factor kind of going on as well, to bring about health, but also to bring about successful pregnancies. And we look at that, traditionally speaking, to kind of put it in simplicity term, when we're talking about immunology, we are really dealing with inflammation and also clotting dysfunction. Those are the two main things that we are looking at, and both of that is important, especially when we're dealing with miscarriages.
I didn't catch that second part, Dr. Kongoasa. You said when we're talking about immunology, we're talking about inflammation.
Mm-hmm.
And what was the second thing you said?
Blood clotting. So when
blood clotting.
Blood, yes.
Okay.
So venous thromboembolism, for example, one of the reasons in patients with autoimmune conditions why they can have recurrent miscarriages is because the blood clots within the placenta, and then that causes the miscarriages. So we have to kind of start treating with blood thinning agents. Some patients needs to go on Lovenox, and with the inflammation is when you mount an immune response, you're mounting an inflammatory response. So things like steroids can help kind of keep the immune response down, so that I guess the fetus is not being attacked by mom. So those are the two main things that we are dealing with inflammation. Yeah, we can go kind of more into details, looking at the natural killer cells, for example. So that is one of the area that I feel that hasn't really been studied a lot yet. But I think there's a huge potential, and it does definitely go in line with our restorative approach, especially in the treatment for recurrent miscarriages.
Yeah, I think I think this is a concept that might be new to a lot of people, thinking well, what the heck does my immune system have to do with my reproductive system, right? Even though it's all in the same body, I think that's a new concept for a lot of people, but that's fascinating that we're talking about inflammation and blood clotting. And of course, those two things can greatly affect what's going on in the uterus when that baby is trying to implant.
Yes, yes, and I mean, we see kind of like anecdote. I mean, all diseases are interconnected. You know, in someone, in someone, for example, with endometriosis, we know that endometriosis will cause some hormones, some ovulatory dysfunction. We know in that endometriosis is a highly inflammatory condition, and we know endometriosis, you know, some aspect of the endometriosis also affect the physiological function of the endometrium. So I think that all of diseases are interconnected. In PCOS, for example, you know, we know that it's a huge hormonal imbalance there. Women are not able to ovulate because their hormones are out of whack. We also know that patients with PCOS also have high inflammation as well, you know, and that's why we see that in some women with ovulation, just by changing their diet to an anti-inflammatory diet, that can help with some of the symptoms. And we also know that PCOS can also be a physiological dysfunction as well, and perhaps that's why, you know, wedge resection is successful in some patients with PCOS. So I think all diseases are interconnected, and we need to kind of see if this disease, how does it cause the endocrine system? How does it cause inflammation, and what does it do to the physiology? And try to kind of correct that as well.
I think that's an excellent point. Just looking at all of this as all interconnected is a totally different approach from just saying, okay, heavy periods, you know, let's get rid of that. Or something's painful, let's get rid of that. But like you were saying, what's the underlying cause of why? And what's going on amongst all of these systems? What's going on more specifically in this particular woman's body, right? Because as you mentioned a little bit, something like PCOS can present very differently in a different woman. And, you know, especially if there are other things going on with endometriosis, or, you know, hormones are unbalanced or something. What is the whole big picture for this particular woman, right?
Right. And that is not always easy, you know. Then it's very personalized, and I think a lot of it will kind of come down with lifestyle, right? So one of the more common questions that patient asks when I start them on medication, like low dose dexamethasone, for example, or metformin, you know, the next question is, how long am I going to be on this medication for? And you know, I don't really have a good answer for that, except that what I tell patients is that is, you know, medicine is only part of the treatment, and medicine is going to help you with your symptoms, will kind of help with the restoration very quickly, but you also need to have another branch going on as well, which is kind of, you know, the diet and the lifestyle. You know, I do believe that there are that we need as a society, you know, we as a generation, actually, we need to be taught again on what is eating, what is exercise, you know, and like, you know, kind of the concept of farm to table, for example, is something that is unheard of in my grandparents' generation, for example, because everything is farm to table. You know, we are eating a lot more things with that is inflammatory to us, and also exercise as well. You know, why exercise is good and things like that. So I think a lot of this is also boils down to how a person lives their life as well.
Because I can imagine that, but we don't want to tell women, you know, this is your fault that you're dealing with these issues. Sometimes our environmental factors and the things that we're eating and the way that we're living can contribute to the body not being, you know, in a completely healthy state, right? And so, and that happens over time. So I imagine the same thing, you know, when we go back and try to fix those, that's going to happen over time as well.
Absolutely, absolutely, and that's why it's great to kind of to have this kind of collaboration, for example, with a nutritionist and an exercise physiologist, for example, because like I said, I do not know what is the diet for you, or I do not know what type of exercise that will be beneficial for these metabolic issues. But these areas have been studied, and there are experts out there that can give us very good information on these topics as well. Um,
That's great. Thanks, Dr. K. The third area is physiology, and you mentioned that a little bit, but I think that ties in with the surgical part. So, and I want to talk to you about that specifically, the concept of restorative surgery. Can you give us some examples of reproductive health problems that you use surgery in order to restore health?
so I would say the major one is going to be infertility. I think that when I was in residency, for example, surgery is not part of a infertility workup, and for a long time I thought, yeah, not everybody needs to have surgery. But my mindset has changed, because I do feel that there are certain things that medicine can treat, but there are also certain things that can only be treated by surgery. So if a patient have cervical stenosis, for example, cervical stenosis is when you have adhesions within the cervical canal, and that can reduce the production of mucus.
Sure.
And we typically see that in patients who had perhaps a PID in the past, or not so much PID in a classical sense because of sexual transmitted disease, but more kind of like a vaginal infection ascended to the cervix, and that can cause adhesions. We see it also common in patients who has multiple IUI, for example, or who used the history of IUD in the past, for example. So those are risk factors. And when you have adhesions, then you are not going to produce good mucus. When you don't produce good mucus, then that can lead to infertility. So physiology is kind of treating that when we are dealing with endometrial polyp, for example, and that can cause bleeding in between your cycles. That has no pattern. So that again is an issue with physiology. There's an abnormal physiology right there. Tubal physiology as well. That is again more in the sense that if you have kind of proximal tubal blockage as a result of infection, or a distal tubal blockage as a result of again PID or endometriosis, or just scarring in the pelvis. So we treat that individually, and you can already see that all those can lead to infertility, or can be a cause of infertility. And a big one, of course, is endometriosis. Going in, kind of addressing the endometriosis, taking down adhesions. So I don't think that you can categorize women as to have unexplained infertility before truly looking into the endometrial cavity, into the vaginal cavity, into the abdominal cavity, and try to fix that. Because if you have any of those issues, for example, you can give a woman a perfect hormonal picture, you can give a woman kind of perfect neurological, but if the problem is still mechanical, you're still not able to do that.
Right. That is a really interesting point that you make. There are thousands of women who get this unexplained infertility diagnosis, but nobody's ever gone in to look, right? So you're actually talking about using surgery as kind of a diagnostic tool, and you go in there and you can fix things as you see them as you're there too, right?
That's right. So we go so we look for causes for infertility, but we also treat it at the same time. Um, yeah. And I know one thing that I see very frequently is that women, they have been on different type of fertility treatment for 5 years and she never had any surgery.
Wow.
And that is a shame because meanwhile, the egg quality has gone down, the egg reserve has gone down as the woman age, but also disease also progress more quickly as well. Whenever you give a woman very potent fertility drugs, for example, in women with endometriosis, when you give them, when you stimulate their eggs for oocyte extraction in IVF, for example, that woman is being given a high dose of estrogen that can actually flare up the endometriosis more. So what that means, it makes the endometriosis, it can make the endometriosis progress at a much faster rate.
Wow.
Whereas if that had been done in the outset, kind of like on year zero, for example, then we would have treated endometriosis,
Right.
and then a woman would be able to get pregnant.
Right. Right. Yeah, this is a great point, I think, because, and especially that you talk about it as a combination of eating and lifestyle changes as well. We know those things are important, but this point that there are certain things that you're never going to be able to change, at least all the way. Maybe you can get endometriosis under control. Maybe you can maintain symptoms or pain with diet and lifestyle changes, but you wouldn't actually be able to completely eradicate it without going in with surgery, right?
Right.
I want to make sure I'm stating the right thing.
No,
what you're saying.
Right, and we have to kind of constantly think about those three aspects all the time. I think that, and we do that all the time without even realizing it, because we give, and at least in the restorative reproductive medicine community, we give mucus enhancer, right? And we look at the patient's mucus score, or we look at the patients, and we try to fix that at the physiological level. We try to improve that. Meanwhile, while waiting for the labs to come back, while waiting for the hormone profile to be done, right? So we do that all the time, really.
Yeah, I love it. I think it's a fantastic approach. I mean, I have gone through it myself with 7 years of infertility, and then digging into actually the underlying issues, and we were able to resolve those. So in your gynecological health practice, you are learning restorative protocols for a number of different medical management models, which I think is fabulous. And namely, I see that you offer FEM, medical management, NAPR technology, and the Marquette University protocols. Correct me if I'm wrong, but this is pretty unique in the industry, right? And
right.
Why? And then why are you collecting different protocols to use?
So I think that it's funny because I was thinking about this question the other day. I was thinking that the reason why I'm motivated to learn about all the different protocols is so that I'm not bound by a protocol. so I think it kind of it forces me anyway to kind of question why are certain things done differently. What is this trying to look at? What is this protocol actually after? What angle is it looking at? And to be honest with you, I don't think that yes, we use protocol to help to guide us, but very often a patient doesn't fit in one particular protocol. We really have to kind of look at the symptoms. Let the chart tell the story as well, and kind of based on that, then we take what is good from one protocol to the other, and help the woman. And we also should not be limited to only to the restorative reproductive medicine protocols, for example. They are very good information, very good guidelines out there that maybe don't get a lot of credit for, because nobody is really looking for the answers like the way we are looking for the answers. So there are protocol that exists out there, and I think we need to kind of search for it. And I think the protocols are there so that we can ask more questions about why things are done in a particular way.
I love that. I absolutely love that, because we don't know what we don't know yet, right? So as you're, and it's so awesome that we have all these resources out there that you can use as a guide, like you say, but the solution is going to be as unique as each individual woman, right? And so you can use your experience and your research and the protocols that are out there to put together the best solution for that particular woman. I think it's wonderful what you're doing.
Thank you. Keep praying for me. Keep praying for Atlanta.
You got it. So Dr. K, at the end of each of our interviews, we're asking all of our speakers to share your #1 cycle power tip with our audience.
So ovulation is a vital sign, and I think that we need to start treating that as what it is a vital sign. So whether or not someone is trying to conceive, someone is trying to avoid, that woman needs to ovulate, because it's the sign that they are having a good health. And when someone is not ovulating, then we need to find out why.
Perfect. Ovulation, it's the vital sign. Thank you again, Dr. Kongoasa.
Thank you for having me. Thank you so much.